Good evening, friends. Welcome to this Tuesday webinar programs from Yashoda Group of Organizations. We try to bring the updates and current concerns related to the clinicians across the globe. So today, for the last probably couple of months or so, from May, June onwards, we have seen a surge of fevers, and for a good reason. They are not linked many to COVID, and the admissions related to the COVID are drastically gone down to almost close to zero or a nil admissions. But simultaneously, we have seen a seasonal surge of cases related to the influenza, which we actually brought in the last two sessions. Along with influenza, we have also seen a surge of many tropical fevers, including dengue, and then followed by many of our tropical fevers like scrub and occasionally leptospirosis and some of the enteric fevers. So we thought there are a lot of haywire going around that many patients get admitted, and there will be a lot of delay in evaluation and diagnosis. We know there will be a lot of limitation when it comes to the tropical fever in diagnosing them, because many of the diagnostic test cultures may take its long time or may not be possible in these tropical situations or tropical fevers. So we thought the point of care diagnosis, which was evolved and been there as a standard modality for the malaria and dengue. Nowadays, we are seeing many companies coming up with their own kits of rapid diagnostic for many tropical fevers, including scrub, leptoenteric fever, or chikungunya and all. To discuss that, we had an interaction with Dr. Swathi initially, and who thought this can be a good discussion for the current clinicians right now who are facing a huge surge of fever across. So Dr. Swathi, who is our head of the clinical microbiologist in Somajigoda Yashoda, we welcome you, Dr. Swathi, on board. Ma'am,
thank you, sir.
Yeah. So it's our pleasure and honor to actually invite the professor, the unit head of Unit 1 from the reputed institutes of PGI Chandigarh, Dr. Ashish Bhalla. Sir, we welcome you.
Thank you. Thank you so much.
It is a pleasure and honor to welcome you, and you giving us the valuable time for this program, sir.
No, it's an honor for me to be here and talk to a wide variety of intensivists, general physicians, and maybe even some students.
Thank you, sir. So the flow will be something like that. Dr. Swathi will take us through the brief overview of the different molecular rapid diagnostic tests available for the quick diagnosis. She will also take us through the both the limitations and also the advantages of this test. And after that, we will take our expert's opinion regarding the expertise of his both. He has been leading the emergency department, also a part of heading one of the maybe the most reputed institution of current India with the postgraduates in both ID and also in the internal medicine department. Will take his inputs. So over to you, Dr. Swathi, for your overview.
Okay, sir. Thank you, sir. We'll start the presentation. So good evening, everyone. Thank you for giving me this opportunity, sir. So I'm Dr. Swathi. So today we'll be discussing about the fast and accurate diagnosis of available methodology available for diagnosis of fevers. So we will start with, actually, I would like to understand that most of the fevers are caused by a variety of organisms. So here we would like to bring the concept of syndrome testing. So what is a syndrome testing? Syndrome testing is a symptom-driven broad grouping of probable pathogens into one rapid test that maximizes the chance of getting the right answer in a clinically relevant time frame. So we are now targeting a syndrome testing so that we can look at different types of bacteria, virus, fungi at a given time frame. So a lot of diagnostic tools are available currently, which are time-consuming, labor-intensive, which are technically complex, which are low yield, lacks of sensitivity and specificity, cause and limited coverage, which are confounded by overlapping symptomatology, and need to order multiple tests specific for suspected organisms and availability of tests for many organisms. So what is the difference between traditional versus syndromic testing? In a traditional cell testing, we have one sample and we have to order multiple tests, and results take hours together, which will cause a longer stay for the length of the stay of the patient. Whereas syndrome testing, we have one sample and there is one comprehensive test, and it takes only a few hours to get the results, and which will help us to improve the patient management. So urgent decisions may be needed, especially in critical care scenarios. So syndrome testing offers for the doctors and the infection control perspective to adequately treat it more adequately and to help to protect the patients. For laboratory, it is helpful to detect more faster, and it can be done 24/7. Doesn't require much expertise, and for the hospital, it will help in better patient outcomes and for the savings for the patient. So the syndrome testing involves what we are currently using is a biofare panel, which is a closed system which has got a pouch. It's a pouch sort of thing which comes. So it is based on nested multiplex PCR. So which includes sample extraction, amplification, and detection, all in a pouch. And maximum runtime of the test is only 65 minutes. So once we load the sample moves into the lysis chamber. Cells and the pathogens are lactic acids are bound by the magnetic beads. They move away from the lysis chamber to the purification chamber, and a wash buffer removes cellular and pathogen debris. Now an elution buffer removes the purified nucleic acids from these magnetic beads. So the products from the first stage PCR are diluted, remove any remaining PCR primers, and these products are added to the fresh master mix and are aliquoted into each well of the array. Now, each well is pre-spotted with a single pair of second stage PCR primers, resulting in specific amplification of target DNA only, and a fluorescent double standard DNA binding dye monitors each reaction. A film array performs a melt to confirm the presence or absence of the assay-specific temperature signatures of the second stage PCR product for each well in the array. So this film array, after the test is done and processed, it processes the data, it creates a detected or not detected call for each organism and provides a simple and easy to read report. So we have different panels. In the current scenario, we have a respiratory panel, we have BCID, which is for blood cultures, and we have GI panel, the gastrointestinal panel, and the meningitis or the encephalitis panel. They are recently upcoming with a joint and infectious panel. So the respiratory panel, which is currently available, which is targeting 21 microorganisms at a go, with a runtime of only 45 minutes. So it will reduce your turnaround time drastically, and it has got 97% sensitivity and 99.4% specificity, and it is helpful to reduce the treatment cost because it will detect whether it is virus or bacteria, and it can help you take a call to de-escalate or escalate the antibiotics. So this is a study published by the Apollo Chennai, which is showing that which has included 40 patients on whom the panel was performed, and they have seen that most of them were viruses which were isolated, and in these scenarios, when we de-escalate the antibiotics, there was a drastic improvement in the patient outcome. So this is one of the important panels, especially during the seasonal flus, when the seasonal flus are rampant. So this would help us to reduce the overusage of antibiotics. The second panel we have for respiratory samples is a pneumonia panel. So this targets mainly the lower respiratory pathogens, and it has got 34 total pathogens in it, which includes bacteria, virus, and the most important thing here is this panel gives us the quantitative results. So when there is, suppose you are sending ET secretions, BAL, where you can expect 2 to 3 organisms, sometimes polymicrobial, there you require this quantification or whether how much is the colony count present, so that it will help the clinician choose which is the actual pathogen. So this panel gives you the semi-quantitative results of especially when the bacteria are detected, and plus it also has the advantage of detecting atypical pathogens like Legionella, Mycoplasma, Chlamydia also. Plus it gives you the antibiotic, you can get the different genes responsible. It may not cover all the genes responsible for the antibiotic resistance, but it does cover the most important genes like CTXM, OXA48, AKPC, NDM, etc. So this helps us again to take a decision on antibiotic escalation and de-escalation by the time the culture reports are ready. So antibiotic adjustments can be made, and there is, you get a quantitative results which will help you choose an appropriate antibiotic and know the actual pathogen. So this is one of the papers published, which will help you, which was showing the importance of this, the test, where this test was used to detect especially secondary infections in COVID-19 patients. So how that has helped in their antimicrobial stewardship. So there is a high rate of mortality in patients with secondary infections, which warrant extra caution to improve the infection control practices and the practice of antimicrobial stewardship, which not only helps to save the patient lives, but also prevent the selection of prevent the selection of drug resistance and spread of drug resistant infections. So this panels can be used like this. Yeah, next common panel or the panel available is the meningitis or the encephalitis panel, which can be most commonly used for young infants, elderly patients, travelers, immunocompromised patients, adolescents, children, and adults. According to the European Society of Clinical Microbiology and Infectious Diseases, PCRs are shown to have incremental value compared to the cultures and the gram stain, and 5 to 26% of bacterial meningitis cases in children and adults are caused by bacteria other than Strep pneumoniae, Neisseria, and H influenza, and therefore you need multiplex PCR to be able to detect them because they're not easily picked up in cultures. Pre-treatment with antibiotics again decreases the yield of CSF culture as such. So in such scenarios, PCR is useful before in patients who receive intravenous antibiotic treatment before lumbar puncture. In neonatal meningitis, CSF cell count leukocytes and are frequently within normal range or only slightly elevated, particularly in case of enteroviral meningitis. So in such scenarios, this panels helps us pick up different pathogens. So this is BCID panel, which has got 43 targets. The main disadvantage or the drawback of this panel currently is, as per the recommendation of the company, we have to use it for a blood culture positively after the blood culture is flagged positively. But there after that only we can use this panel as fluids. So as such, there are no studies published, but still this isn't this. We did see 1 or 2 cases where the organisms are get picked up from these things. The most important here is it is giving us the colistin resistance and the methicillin resistance along with VAN A and VAN B, which was previously missing in the BCID1 panel. So here you require positive blood culture, which is a major hindrance as of now, because we hardly get positive blood culture bottles in a patient who is already treated long time in the critical cares. So here but the performance, sensitivity, and specificity is 98 to 99%. So to summarize, syndromic testing is a need of the hour. It is fast, easy, and comprehensive. And it is like you can say it is a right test for the first time if you can do, though the cost is high, still it will help a lot for the patient. So still apart from this is BioFire film array, what I was talking previously, which is a closed system. We can't add pathogens or we can't remove pathogens. It's a closed system and it's an FDA approved kit. But in market, we do have other platforms where it is an open multiplex PCR, like you can see different panels which are being marketed by different companies, which are available currently. But the major problem with this kits is that we don't know whether the reports, how far we are reliable, how is the repeatability of the test. And secondly, suppose like this report, if you are seeing Salmonella species detected low. So now it is a clinical challenge, whether low doesn't mean anything. Sometimes it may be incidental finding or it may be an actual pathogen. So here in this particular report, we find that whether it is again going back to the clinician only, whether he has to take a call, whether this has to be treated or not based on the patient condition. So here the problem with this test is most of the time the primers they use, there is a questionable quality of the primers they use. And secondly, the other limitations are a negative result does not indicate the absence of pathogen. And since PCRs are highly sensitive, there are several reasons for paradoxical results, which include interference by inherent inhibitors and degradation of DNA due to pre-analytical errors. Diagnostic errors can occur due to mutations in the primary binding site. So the primer which we are using in this particular, the mutation might have been there in the organism, so it may not bind to the organism, though the organism is present in the sample given. And detected result will not distinguish a viable and a non-viable organism. And sensitivity of the test would be influenced by the quality of the sample submitted and what stage of infection we are submitting the sample for testing. So all the PCR tests, when we are doing it, it has to be interpreted with caution. It has to be clinically interpreted in relevance to the clinical scenarios. just because they are sensitive, whatever is positive cannot be taken as positive, considering all these ifs and buts of the test. Now coming to atypical pathogens like scrub typhus. Scrub typhus is a disease which is caused by bacterium that is Orienza shushugamushi. It is transmitted by the bite of the larval stage of trabecular mites, which is commonly and clinically important rickettsial infection worldwide, especially in Asian countries, including India. The signs and symptoms of scrub typhus are very non-specific, and they resemble other tropical infections which are endemic to our country as such. So here the gold standard as routinely described by all textbooks is IFA, that is immunofluorescence, which is not generally available and it's a cumbersome process. We require equipment to do it. Other modalities like POCT is rapid testing, which is ICTs, which are available. And we have IgM ELISAs, which are most commonly done. So here the IgM antibody formation after the onset of illness and resultant positivity of various serological tests will take minimum 5 to 6 days. So this additional challenge in performance of this serological test is that this particular bacterium will have multiple antigenic variants, which are caused by the changes in this outer membrane protein, and that is 56 specific KDF specific antigen. So this is one major challenge which may cause false positivity also or false negativity. So ELISAs and RDTs were superior tests compared to IFA by in one of the studies done by Kanan and et al., where they have reported that ELISAs and rapid diagnostic tests are better than IFA with greater specificity. And there are PCRs available which are still in developing stage and not commonly available or easily available for us to be done. Now coming to leptospirosis, which is caused by, this is a pathogenic bacteria called leptospires that are transmitted directly or indirectly from animals to humans. So the gold standard, which can be done only in referral laboratory, is direct observation of leptospires by dark field microscopy, which is unreliable and it's not mostly recommended, though it was considered as gold standard before. And isolation of leptospires is not a possible thing. So it is usually the diagnosis will boil down to serology or enzyme, that is ELISAs, and microscopic agglutination test. But limitation of serology is that antibodies are lacking in the acute phase of the disease. You will not be able to detect antibodies in the acute phase of the disease. The gold standard microscopic agglutination, which is like you have to use live leptospires and incubate it with the patient's serum and see the dilutions. This is not widely available because using of live leptospires itself is a very cumbersome and risky thing. Next, we have another option is RT-PCRs, which are using the LIP-L2 antigen, which is very specific to the pathogenic leptospira, which is available, which are found. This is 100% specific, but it should be used in first 10 days of illness for a reliable results. The widely used test is finally IgM ELISA, where you can actually, it's a very reliable test. You can single sample testing is sufficient. You don't need to do paired sample also. So which is unlike MAT. So in MAT, if you are doing microscopic agglutination, we may require paired sample to see the rise in the titer, but that is not required once we go with IgM ELISA with a positive means single sample positivity also, you can take it as positive. But we have, if we do a real-time polymerase chain reaction, it has to be done within first 10 days of illness. We have another platform available test called Express Flu and RSV test. This is based on the Cepheid or the Gene Expert platform, which is commonly used to diagnose TB. So they have recently introduced this Express Flu or RSV test, which is again a multiplex real-time reverse transcriptase PCR assay. So this is intended for the in vitro qualitative detection and differentiation of influenza A, B, and RSV viruses. So in this test, you will know the sample has got influenza A, B, or RSV. So, but problem here is negative result does not preclude influenza virus or RSV infection and should not be used as a sole basis for the treatment or other patient management. The current available kits, the performance characteristics were established during 2015 to 16 influenza season. So as we know, the influenza virus keeps changing its antigenic variants. So we as the viruses are emerging, the performance characteristics will vary for these PCR assays. So this is how we get the interpretation of the test. So we have different melt curves for different viruses. When we run the test, we get the curves, and it is the machine interprets as flu positive, A1, A2, flu B, and RSV, and SPC is a probe control. So the probe control has to pass, compared, and the results are interpreted based on which curve has gone above the baseline or above what is the interpreted value or CT value given for the equipment. So we can get combination of this. we can get only flu, we can get only all the 3 positive. So we see different scenarios in a given sample. The sample here again is nasopharyngeal swab, as we do for any COVID or any influenza test. The sample here has to be nasopharyngeal swab, which has to be loaded onto the equipment. Now coming to the malaria. Malaria, which is very endemic in our country, in some areas of our country, still we have rapid diagnostic tests are being developed, which is based on ICTs, which are based on detection of malarial antigens which are present in the peripheral blood. Most of these tests, they use monoclonal antibodies and they detect particular malaria antigens in the blood specimen. Tests have been developed that detect antigens including histidine-rich protein, that is HRP2, aldolase, and parasite lactate dehydrogenase. These are the 3 basic things against which the tests are being developed, which are produced by the parasite when they are in the body. So these tests, their results are generated within 15 minutes and they do not require any skilled microscopy people or someone has to see the smears. So this can be done on the whole blood as we receive from the patient. So the commercially available test will detect, HRP2 will detect, and therefore they will diagnose only Plasmodium falciparum malaria, most of the case. So these HRP2 antigens, they are synthesized and released by the trophocytes and the immature gametocytes and persist stages, and they persist in the peripheral bed. So what happens is, since they are released by these different trophocytes and the immature gametocytes, they can remain positive for up to 2 weeks following the therapy, or after we give even anti-malarial therapy, still we can find the test to be positive. And parasite clearance as confirmed by Mike. These tests have low sensitivity and detecting infections with low parasitemia and mature gametocytes. In contrast, if you are seeing the smear with you, if it is a very good, who is already trained very well, he can see parasitemias as low as 5 to 10 parasites per micro ml also. The early test reports false positive due to cross reactions with rheumatoid factors sometimes. Now coming to parasite lactate dehydrogenase, this is produced by the asexual and sexual stages of gametocytes of malarial parasites. So the tests that are currently available will detect all 4 species of Plasmodium. They can distinguish Plasmodium falciparum from non-falciparum species, but cannot distinguish between the other 3 non-falciparum species, that is malaria, oval, and vivax. So the tests that detect lactate dehydrogenase do not generate persistent positive results following chemotherapy, unlike the HRP2 test. So here the limitations of the RDT test in case of malaria is it can't detect mixed infections or all species of Plasmodium. It solely depends on the kit we choose. Then infections at low concentration of parasites, the chances of getting missed is there, and inability to monitor response to therapy. In addition, in case of a negative result, still microscopy is recommended. Therefore, the rapid diagnostics do not eliminate the need to see the smears and maintain the expertise. It's still a global priority until we have a new gold standard developed. RDTs only help us in choosing or in taking a preliminary call, especially these can be used in areas where it is more endemic. Malaria is more endemic. This helps us better. And especially in areas where you don't have lab facilities, where you don't have a trained people who can see the smears. Now coming to our most common infection, dengue. So as we know dengue, how it caused. I'm only highlighting what are the various methods of diagnosing dengue we do have available. So the first method is virus isolation, which will be highly specific, which is reliable, but it identifies different serotypes, but it is not an easy thing to do. And it requires expertise and a lot of equipment, and you have lower sensitivity and expensive, and it requires a lot of laborious steps. Now coming to genomic detection, again coming to PCRs, it is highly specific, extremely sensitive. It is possible to determine the serotype. You will get results within 24 hours, provided there is continuous facility to run the test, and it has reliable outcomes. Again, it involves a lot of expensive equipment and requires an acute phase sample. Coming to antigen detection, which is the most common thing, which is rapid results, you have to confirm. This is it will help you to confirm the infection. It is less expensive than other tests, but problem is it has lower sensitivity and higher cross-reactivity with other flavivirus antigens. And it has got false positive or false negative results. Now coming to antibody detection, which is inexpensive, it can detect primary. The antibody detection helps us to differentiate between primary and secondary infection. So high cross-reactivity again is a problem here with other flaviviruses like chikungunya, etc. IgM levels may be low or undetectable in some secondary infections. And it again depends on what type of, suppose it's a secondary infection, IgMs goes down very fast, IgG starts rising faster. And lower sensitivity, you require a febrile sample. Confirmation requires 2 or more. You again need a paired sample here to rule out the dengue. Dengue has to be ruled out with paired sample testing. Single sample testing sometimes may miss the infection. In case of dengue, there was a study which has compared 8 commercially available immunochromatographic tests, and what they have concluded in that test is no RDT will adequately differentiate primary and secondary dengue, and they should be aware of the diagnostic and accuracy, because what the manufacturer claims, we don't usually find it when we use confirmatory tests like ELISA or any other method. So acute specimen, if an acute specimen is yielding negative result, you should always test your RDT with a convalescent serum sample and then confirm the result. So RDTs have to be used with caution in case of dengue. And they also vary according to the serotype. Their problem is we don't know the serotype when we are taking the sample for preliminary or the PCOT. So when there is a dengue 1 serotype, we may you will pick it up easily, and dengue 4 being the least, you may not pick up dengue 4 type of serotype. And you have a false positivity rate is very high of 8.1%. You can see false positivity with other viral and bacterial as well as in healthy donors. This and false positive results have dengue NS1 has been reported with other viral infections like Zika virus also. And concurrent flavivirus infections are most likely to result in false positive, as the IgG antibodies used to detect dengue NS1 can cross-react with NS1 protein of the other viruses. Now coming to typhoid. So it has been a major challenge always to diagnose typhoid accurately, ours being an endemic country, because again, there is a lot of overlapping of the symptoms. So the most sensitive and the specific diagnostic test for typhoid is bone marrow culture, followed by blood culture. But bone marrow culture, as you know, it is very cumbersome. It requires a lot of technical expertise, and it cannot be performed as a routine diagnostic procedure for any fever. Secondly, coming to blood culture, it has got again limited sensitivity because we are already giving antibiotics, and the sensitivity further comes down because of this antibiotic usage. Now we are left with, we don't have a proper reference standards as such for diagnosing or for evaluating the accuracy of the typhoid diagnostics. Serological tests for typhoid are a particular challenge because the surface antigens for the typhoid salmonella are generally conserved. They're also shared with many other enterobacteriaceae. So there is a lot of cross-reactivity between the antigens compared to the other enterobacteriaceae like E. coli, wherever there are flagellar, especially motile bacteria, where they have flagellar antigens. This means that diagnostic kits aimed at general mix of Salmonella typhi antigens frequently suffer from low specificity. Secondly, we being an endemic country, the questionability of IgG positive in a rapid test is a big question. We don't know whether the patient is really suffering from typhoid, or it is because of endemicity, or because of getting colonized, or he's getting positive. And we are not able to differentiate vaccine-induced from infection-induced. You can't differentiate a vaccine-induced antibodies from infection-induced antibodies, especially when you are using rapid diagnostic kits, unless patient is able to give you a proper history. So when there is a comparative study done with typhoid with Vidal test, so they compare now with the current scenario, we can say that enzyme immuno or the typhi dot is more sensitive and specific test, which is easy to perform and reliable when compared to Vidal, which was an age-old test that is useful in early therapy. So coming to the other pathogens like Legionella, which is another cause of fever, we have different diagnostic modalities like direct fluorescence antibody staining, indirect fluorescence antibody test. We can do cultures, and urinary antigen and polymerase chain reaction. But the most common and easily available is urinary antigen, which has got a sensitivity of 70 to 90% and specificity of more than 99%. Culture is again not possible in routine labs for Legionella. So the most common and easily can be done is urinary antigen. The turnaround time is hardly 15 minutes for the test. We have rapid kits for this. So yes, we need to put the antigen. It's like any other, we need to put the urine sample onto the kit, and it is like any other ICT, we get the bands. Next, coming to melidiosis, now we are seeing a lot of melidiosis cases also once in a while, which was very rarely seen previously. So again, culture is a gold standard. We can follow it by IgM ELISA compared by fluorescent microscope. Now coming to chikungunya. Chikungunya is like coming under IgM capture ELISA is a routine test and the gold standard as of now available. Culture is again questionable. We can't do it in a normal lab. It requires a BSL level 3 laboratory. So with the available facility, culture is a gold standard, followed by lateral or the ICT or the immunochromatography. So here I'll end my talk. These are the various infections I could cover. So anything else you want, I mean, you will discuss it further.
Right.
Thank you, sir.
Yeah, thank you, Dr. Swathi, for that elaborative presentation. See, I think she covered all the spectrum of the current tropical and viral illnesses. I think for the last couple of years or more, we have been suffering with unprecedented pandemic, looking for this RT-PCRs and RAT tests based diagnosis of COVID. And right now also we are using parasite V and F as a kit, as she pointed out, a rapid kits which are available, and dengue being another phenomenon where we use these rapid diagnostic kits. But there are many areas like what he was saying about syndromic panels, which are being used for CSF detection, respiratory panel, and once the blood culture grow from there, the panels. And also she was talking about many tropical related panels. So that's an elaborative overview. So we know there were many limitations and there were some advantages. It's an evolving science. So from here, we will take Dr. Ashish Bhalla's expert opinion. Sir, last couple of months being again a surge, what we generally see pre-COVID seasons. So that's the same pattern we are seeing in this part of India. Sir, what is your experience and what is your view there? What is happening right now, sir?
Let me take you back to last year. Last year, 2021, around the Sera Diwali time, people had taken off their masks, and there was a COVID. Second wave was on decline at that time. That was the time we were seeing a lot of influenza B, because the presentation is very similar. And then we asked our virology people at PGI that in case we have an acute respiratory illness, lower respiratory illness, you do a COVID, and if COVID is negative, you do influenza. So give us the detail. We picked up quite a bit this year also. Just before or onset of monsoon season, and even now, we are seeing a lot of influenza, although it has come down. COVID has come down significantly. Most of the time, the respiratory illnesses which are coming are because of influenza. Now, stands to reason that you want to do maybe a multiplex PCR, a diagnostic test, which gives you a wide variety of information in a little bit of time. But what is very important is, what are you going to do with that information? If I know it is COVID negative and if I know it is influenza positive, I'm going to give oseltamivir. For rest of the things, for rest of the viruses, I may not have anything with me. That is one very important lesson we learn. As an epidemiological purpose, for screening what viruses are there, these panels are very good. Let's talk about the encephalitis panel. I know that I may be able to pick 8 or 10 viruses in the CSF. What am I going to treat? I am only able to treat HSV. If I am having a test which tells me HSV and the next possible JE, which can't be treated, supportive management, I'm good to go. These multiplex PCR tests are very good epidemiological tests. So they'll tell you, as a screening modality, they'll tell you at one given time what are the viruses which you were not anticipating. You can pick them up. But I would say that there are plenty of rapid diagnostic tests available. Use them wisely. You have to know when to do a test. Now, let me give you an example. You have a patient who's come to you with acute onset fever and there's no localization. So are you going to do COVID? Yes, there is a possibility that this patient may still be having COVID, and we found a lot of COVID. What is the next best thing? What is the next best bet right now? Right now, the next best bet is dengue. It is not malaria. Although there are pockets where we had seen malaria. How best can I diagnose malaria? Rapid diagnostic test. She elaborated on rapid diagnostic test. And she said very nicely, if you read the literature, they have got a very good negative predictive value to the tune of 95% plus. If I do one test, rapid diagnostic, it is negative. I do another test maybe after 3 or 4 hours or 6 hours, and both the tests are negative. There are 99% chances that I'm not dealing with malaria. Still, if you have a clinical doubt, I'll send it for microscopy testing. What is the next thing which I'm going to do? I want to test for dengue. Fine. I want to test for chikungunya. Is my management going to change? No. Even if I get NS1 positive, what am I going to do with it? Nothing. What is happening is you have, I'm sorry, it happens even in PGI, not in private sector only. You set a panel of tests. You will send enteric day 1 or day 2 fever. What are you going to get? Nothing. You will send IgM ELISA for leptospira. You will send IgM ELISA for scrub. What are you going to get? Nothing. Positive. Because these serological tests, one, they have cross reactivity. Second is they take 5 to 7 days to become positive. On day 2 of fever, if you send dengue IgM, it is likely to be negative.
True.
Between day 2 5, if you send NS1, NS1 might have disappeared. IgM may not have appeared. So these are the tests which you need to order. Are you going to order Vidal on day 1 or day 2 of fever? It's not going to give you anything. You have to give it, you have to send blood culture. That's important. So the things which I would suggest is that at this point in time, if there is a patient who comes to you with acute onset fever, you are absolutely right in doing rapid diagnostic test for malaria, because if you have high, India is still endemic for malaria. You pick up malaria, the treatment differs. And if you leave it untreated, the complications are. Second test, which I want to actually rule out, is whether there is any presence of COVID or influenza. There are enough studies which have shown that the most common infection in the community is number 1, influenza. Number 2, number 2 is scrub, and number 3 is dengue or chikungunya, depending on the year in which you do the studies. So these are important in the community. But if you look at the hospitalized patients, influenza patients don't get hospitalized.
True.
So you will get scrub, you will get dengue, then you will get malaria. You will get scrub, dengue, leptospira, and then you will get malaria. So this is important at what stage you do these.
Ashish sir, actually, as you rightly pointed out, we have rapid diagnostics which has been evaluated and probably has tested for COVID, which we have been using RT-PCR and rapid diagnostic RAT test for the last couple of years. And also influenza, we have RT-PCRs which has been used for almost from 2009 onwards still. That's been evidented. And dengue, yes, we have some evidence, but whether the applicability and use of it in a case to actually evaluate a sicker group of patient who is going into from a febrile phase to a critical phase, maybe a role to play to actually keep a watch on them, keep some giving a volumes or keeping monitor them. But now we are seeing a lot of, as you rightly pointed out, other tropical fevers. Malaria has not been a surge in the last maybe 2-3 months. We have not seen many malarias. As you said, COVID gone down, influenza picked up in a high rate, followed by dengue cases being high in during this last 2 months. And recently we are seeing a lot of patients where we see patients coming with fever, on and off rash, and then we see some of them have hepatitis involvement. and scrub being positive in many of them. And we are talking about well-Felix test, ICT test, and some IgM antibodies, and also this rapid diagnostic PCRs. So first, from your point of view, is there any surge we are seeing in scrub? You pointed out that may be the second in the list of hospitalized patient, because we are not seeing any influenza coming in. And depending on the seasons, it may also lead to the top. So can you elaborate on that? Because scrub is one of the underdiagnosed PUOs in many institutions, many even private and public sectors. Probably many of them empirically get doxy, they get treated unknowingly and they get better. But your take on that, what is you see in this last couple of months and this rapid diagnostic related to the scrub?
Yeah, you brought this point very rightly. As I said, in community, scrub is number 2, right? Influenza is number 1. In hospitalized patients, acute febrile illness, I'm not talking about PU. PU is 3 weeks. We're talking about first 2 weeks of illness, right? So in first 2 weeks of illness, scrub is number 1. In most of the studies, even from South, I was talking to someone the other day.
From CMC Vellore also the
CMC Vellore, it is around 47%. PGI Chandigarh, it is 45% of acute febrile illness is scrub typhus. So there is a reason for giving doxycycline because that has come out as a major. Now, how do you pick it up? Can it be picked up in an acute setup? Very difficult, very difficult. As I was discussing with you earlier, eschar, if it is present, it is helpful. But eschar, if you just casually look for it, 30%. If you specifically look for it under the breast, under the scrotum, in the scalp, you would increase the yield to up to 45 to 50%. Now, what do you do with this if you find an eschar? As Swathi said, that there are some PCRs which are being developed. If you have an availability of scrub PCR, either in a lab or at your own institute, do that because the positivity from eschar is very high. Now, in the absence of eschar, how are you going to make a diagnosis? There, the diagnosis comes from giving an empirical treatment with doxycycline and seeing the response. If there is hardly any resistant reported in Southeast Asia to doxycycline, right? So if you give doxycycline and the fever starts subsiding within 48 to 72 hours, take it for granted this is scrub typhus, nothing else. If it does not subside in 48 to 72 hours, then you think of something else. Similar thing happens in leptospirosis. It can present with multi-organ dysfunction. In both the cases, the test to perform is IgM ELISA. And IgM ELISA will not be positive up to day 5 to day 7, beyond day 7, right? Let's say you send a test on day 7 and it is negative. You send it again after 40.
Again after 1 week, yes.
That is important. Another clue which she has kind of, given you is a false positive Vidal. Very many practitioners order Vidal in the first week. It shouldn't be there. But if it is positive, there is a false positivity with scrub typhus. So that can give you an idea. Yes, this might be, but then again, it will come after 1 week. It will not come before that. So if you have an acute febrile illness, there is a very highly likely chance that it may be viral fever or it may be a bacterial infection with scrub. So you cover scrub with doxycycline. And for viral illnesses, you only give supportive treatment. So there is a strong case for giving doxycycline as an empirical treatment if you find scrub as an endemic disease in your area. This is what we do in PGI.
So now there are two quick questions related to the scrub. There is a lot of use of higher doses of doxycycline 200 milligrams IV twice a day. Do you see any reason for that?
No, no reason. You have to give a loading dose of 200 milligram on day 1. That is the first dose. And after that, it is 100 milligram, which is good enough. The problem comes is scrub and leptospirosis both act as infective vasculitis. They can have very severe complications in the form of myocarditis, ARDS, and meningoencephalitis also. So there you may think of giving some kind of immunosuppression, uh, maybe, or immunomodulation, I would say, in the form of steroids or IVIG to tide over that acute crisis. Again, to tell you, if you have influenza, last year we saw with influenza B, we saw a lot of myocarditis. So that you have to take care of. With dengue, you do not see a lot of myocarditis. But all these illnesses, scrub typhus, dengue, chikungunya, all of them can cause persisting fever which lasts beyond 7 to 8 days. There you have to think in terms of macrophage activation syndrome, because that is also an important consideration, especially for critical care specialists. You talked about critical care specialists. By the time the patient lands up with you, he would have developed complications. Dengue would have developed complication. Enteric would have developed complication. In dengue, the complications start happening after 7 days. So there your NS1 will not help you. It will your IgM and IgG. Enteric will come to you in week 3, week 2 beyond. There your blood culture may still be positive, or Vidal might help you in suspecting that this could be enteric. Leptospira and for scrub typhus, they will come to you probably early in the disease, because they end up developing complications much early, and they can have varied complication, ARDS being the most common, and the second most common is meningoencephalitis. There is a role of giving empiric doxycycline.
Now we talked about doxycycline. As you said, some of our patients may land up multi-organ failure, gut may not be available. We may be giving doxy. We also know that some of these scrubs may have a sensitivity to azithromycin, which we have seen using in enteric fevers also. Some of our clinicians in a sicker group of patients empirically may consider azithromycin as an empiric choice. What is your take from the azithromycin point of view from scrub?
I was just reviewing a paper today, and it clearly proves that we have misused azithromycin in COVID-19.
COVID, very badly.
Doesn't help. We have misused azithromycin in influenza, doesn't help. The only place of azithromycin where we had included azithromycin is community acquired pneumonias, where you want to give ceftriaxone and azithromycin,
one of the macrolide,
or any macrolide, to cover for atypical organisms. Now, that would cover your scrub. Azithromycin is a very good cover for scrub. Azithromycin will also cover your leptospirosis. Azithromycin will also cover your atypical organisms which are there, right? So that helps in that manner. But the problem with azithromycin is, one, very many people don't tolerate azithromycin. And second, if you have a liver involvement or hepatic involvement as a part of multi-system involvement, you want to avoid azithromycin. So you have to be very selective in using azithromycin when you are strongly suspecting an atypical organism, strongly suspecting either scrub or leptospira, you can use it. But in a viral illness, in COVID, in H1N1, in RSV, there's no role of that.
Sir, what about your view in now we are seeing enteric fever being resistant to many, but ceftriaxone and maybe azithromycin a gram in combination with ceftriaxone being recommended as a standard therapy in bacteremic patient with enteric fever?
Uh, there is a very nice study which has come out from CMC Vellore, and they have done a trial on giving azithromycin 1 gram for 7 days in culture proven.
We are seeing a problem.
Hello.
Yeah, sir. Please go ahead. There is a
Ah.
second internet break.
When I was a student in Harrison textbook of medicine, the treatment for enteric fever was 1 gram ceftriaxone BD for 3 days. Doesn't work anymore. Doesn't work anymore. If you have a convincing reason for not using azithromycin, you can use ceftriaxone, right? But we've seen in some patients up to day 10 or day 14, you do not get a response like you get with azithromycin. If the patient is not responding, then there is a reason for combining the two drugs. Otherwise, ceftriaxone, what we follow at PGI is that we give either azithromycin 1 gram alone or ceftriaxone alone. In case the patient is not responding within 72 hours, there is no defervescence. With azithromycin, we may add up ceftriaxone. Otherwise, majority of the patient would end up responding. I'm talking about culture positive enteric fever.
So there are questions related to a lot of mixed infection, co-infection has been seen in recent times. Patient presenting with RT-PCR positive, RAT positive. Later on, the pattern not matching. So when we actually saw for a H1N1, they turned to be positive. So the pneumonia patterns were more matching to the typical influenza-related pneumonias on the ARDS. Sometimes we also saw dengue being overlapping with asymptomatic COVID patients. Scrub also being seen overlapping. What is the pattern you're seeing in that part of the world, sir?
We saw it last year. A lot of patients who were COVID positive and dengue positive. There were a couple of patients who were COVID positive and scrub positive, right? But why did we suspect COVID and scrub, dengue and scrub in these patients? Because their clinical picture was slightly different from what we were seeing with COVID, uh, uh, pure COVID infections. So that is why they were being done. But take all these serological tests with a pinch of salt, because there can always be a cross reactivity. Right now, we are going through in Chandigarh, in Delhi, an outbreak of chikungunya also, which is coexisting with dengue. So you are having clinical picture of high grade fever with joint involvement, but you are getting dengue IgM positive. So there could be a cross, she's already talked about it. There could be a cross reactivity with the dengue. So let's say you want to say that dengue and chikungunya coexisting. No, I won't say that. I would think more of cross reactivity and would go more with my clinical understanding of the disease pathology.
Dr. Swathi, can you elaborate? There were questions, there are audience questions related to the cross reactivity. You said dengue virus NS1 can have a cross reactivity, IgM can have a cross reactivity with flaviviruses, if I'm right. So can you elaborate on that, Dr.
Yes.
Swathi?
So cross reactivity is because the antigenic components are shared between different same group of viruses like chikungunya, dengue. These all come under flavivirus, togaviridae families. So because of this, as sir has said, we don't know the stage of the infection also. So at what stage, because every person has got their own immune response. Some will give a faster response, some will give a slower response. So cross reactivity and the stage of at what time are we really doing the test. So this cross reactivity is because they belong to the same family. We can't help it. We can't, narrow it down or remove the cross reactivity part of it. serology has to be interpreted again, coming back to clinical scenarios only. Serology is not anytime the diagnostic, or it may not help you 100%.
There were questions related to what will be the ideal time to send rapid diagnostic in scrub. We all understand the lepto or probably IgM, the initial week, what our clinical experience being, most of the times it was negative. So we have to repeat it in the second week. And in a clinical context where we were strongly suspecting, 60-70% of time we found that IgM to be positive. So probably if we repeated in the first part of the week, so we should be repeating if I am still convinced that this patient probably having a diagnosis
Yes,
is left. What about scrub? What about scrub?
Yes, sir. And we have to look at what type of test we are at. See, rapid test are based, antigen based tests are also available. As in malaria, we have antibody based tests again. So it depends on what type of test your lab using. If it's an antigen based test, maybe it will pick up infectious diseases very few. If it is antibody based test, any antibody will take minimum 5-10 days for the antibodies to develop for any particular infection. So that is a time period. So as sir said, immediately sending in day 2 fever or day 3 fever may not help you. But if it's an antigen based test, dengue NS1 antigen, it will pick up. So again, you have to see what is the test your labs are using, or wherever we are sending the sample for RDT, whether it's antigen based, antibody based. Antigen based in the early phase, but antibody will take minimum 5 to 10 days for any sort of infection. That's a minimum time the antibodies need to develop, or the response, the body needs that response time.
Yeah. What about these paid samples in dengue? Importance of these paid samples.
Paid samples, sir, as we said, so it depends on what type of infection the patient is having. So it's a primary dengue or secondary dengue, which you may not be able to look at clinically. So we are, suppose a patient is with a secondary dengue, for him the IgM response falls very fastly compared to a patient with a primary dengue. And the IgG response for a secondary dengue patient who is already infected previously will come very early compared to a primary dengue patient, or who is getting infected for the first time, and depends on the serotypes. So every time when you feel it is dengue and still the tests are coming negative, we always advise the clinician to send for a repeat sample based on the fever of days of fever. So as I said, some patients by 5th day or NS1 most of the time will get cleared. But the same patient may not have an adequate IgM response where the test can pick it up. Test also will have a range to pick it up. At early phase, most of the tests may not be, the IgM response is, or the IgM levels are not good enough for the test to pick it up. So we have to wait. So maybe we are doing the test at that particular point where the IgG antibody levels are good enough to be picked up by the test. So that is why we always say, if it is still clinically you're feeling dengue and we are not able to get a positive result or elicit a positive result, we always ask for a paid sample. That is, you have to give it, send the second sample within a gap of minimum 5 to 7 days. So that will be the time gap between first sample and second sample is called the paid sample.
Sir, what is your take on this timing of the IgM in scrubs, like lepto?
Well, the same thing. If there is one message which has to be taken by the audience here, if it is a PCR based test, it has to be sent early in the course. If it is an antigen based test, it has to be done early in the course. But if it is an antibody based test, do not do it on day 2, day 3, day 5. Wait for up to day 7 and then send the sample. In the meanwhile, you can symptomatically manage the patient. And if you strongly feel there is some intervention which is required, the clinician has to take a call on this, right? Again, for enteric fever, if you ask me that within first 48 to 72 hours, what are the tests I will order? I will not order any test. If I'm not suspecting malaria, because even if I diagnose dengue in first 48 to 72 hours or chikungunya in first 48 to 72 hours, or for that matter, COVID or influenza, what is the treatment I'm going to give?
There may not be therapeutic options to change.
There are no therapeutic options available. So your therapy will only, if the fever persists beyond 72 hours, then you start scratching your head. If this patient starts exhibiting complications on day 5 or day 7, then you start scratching your head and think of sending investigations.
There are
Till
some
that time,
interesting questions related to so that SCAR giving you the SCAR, how the SCAR, from SCAR we do a PCR technique. That's what one of the interesting question where Dr. Ashish Bhalla was talking about. So Swati, you can elaborate.
Sir, any Eshkar is nothing but is a dead tissue which we get. So any, like we usually when we get tissue samples, we homogenize it, we centrifuge it, or we make it into small pieces, and we use a DNA extraction kit. So all PCRs will have an extraction kit. So these extraction kit function is to, they will extract the DNA from the given sample. It may be a tissue, it might be a blood, it might be a swab, whatever, all PCR based assays, we'll use an extraction kit based on the type of virus, RNA or DNA extraction kit. Once the DNA or the RNA is extracted from the sample based on the type of virus or bacteria we are looking at, then after the viral extraction happens from, and we put it into it where the PCR reaction starts, like with the primers which are supposed to be going and binding to your target that you are looking for scrub in that particular sample. That primer or that probe, you can say as the probe, it goes and binds to the scrub if it is present in the sample. So as the cycle goes on, there is an amplification which we read as a curve. So based on that, that is what comes to our CT value, which all of us have gone to know during our COVID. So that is our CT value. So we come to that level. We have a cutoff for every PCR. When you standardize it, we keep a CT value. So when the CT values, when the reaction is crossing that CT value, that is the number of cycles it requires to amplify. That is how we interpret any PCR. So when we are taking from the scab tissue, we can gently scrape it off and send it in a normal container, and we can do the PCR. It shouldn't, you only have to, we only require to extract the DNA from that particular sample, the viral, the bacterial DNA.
So Dr. Bhalla was talking about many of the patients where initial detection was not there, with the SCAR's tissue amplification method or a tissue extraction method, yielded a more positive reports in them. So that can be a way forward. We see the similar kind of thing when we actually talk about even the salmonella or enteric fever, where the bone marrow aspirates or a bile aspirate will have a higher yield compared to that. So there are some questions related to the dengue rapid testing is not been considered as a standard test in many government notifiable disease list, and ELISA test is not available in many centers, so smaller centers. So your opinion on that?
Earlier, or let me just not get into the controversy. The problem with rapid diagnostic tests in India is the shelf life and the temperature variation. In India, there are lots of temperature variation during the time when you have dengue and chikungunya being positive. There is high humidity, so the shelf life of the quality of the test which you are performing differs from place to place. So that is why the government took a call on saying that we will not give any credence to the rapid diagnostic test, because it was seen that a lot of false positives were being reported by rapid diagnostic tests. And that's why they took this call that NS1 test, antigen test done by IgM, and IgGM or IgG done by ELISA would be, or both the tests done by ELISA would be taken as gold standard. This was to eliminate the bias which was coming because of high positivity of rapid diagnostic tests. As I told you, number one in community is influenza. And for influenza, you really don't need anything. It's a self-limiting illness. Only in a very select group of patients, it will cause severe illness. So there was a problem. That is why the government took this call. This has not happened with RDTs for malaria, because the quality of RDTs for malaria is far better than what was there for. Third thing is, lot of these RDTs for dengue are antibody-based tests. And as Swati has said, there is high chances of cross-reactivity with other viruses, other flaviviruses, rheumatoid factor for that matter. So there would be a large number of false positive on IgM based tests. This is the reason why ELISA has been made as gold standard, both for NS1 and for IgM.
So there is another question related, how long both the dengue and scrub related IgM is generally be positive? Second week, we see this all comes positive after the fifth or first week of time. But how long it remains positive? Sir?
Swathi has already answered that IgM will go down faster if there is a secondary infection, and IgG will come up faster in these patients. By day 5 or day 7, IgM will probably disappear. And that is why you want to, she said, after 5 days, paired sera, I would probably, if I am in doubt and if I strongly want to send a repeat sample within 72 hours, I would probably send a repeat sample and see what is happening to the IgM or IgG.
Dr. Swathi, what's your take?
Sir, regarding this rapid test for dengue, sir, there is one more, as a lab person, I'll tell you the technical problem in it. The test has to be interpreted as per the kit literatures. Different kits will have different. So problem is what happens with this rapid kits is once we put the test. So what happens, the technical staff move away from there. And what we have reached very commonly observed in our practice is once we read the test after the given prescribed time, they might be negative, but if we leave the test for an after prescribed time, we have seen positive rate. I mean, we see some band developing. And second, this is one common thing. So you have to read the test within the time as per the kit literatures or as per the manufacturer instructions. Secondly, transcribing these results. So most of now we have this error in transcription. So what we may see positive may come into your report as negative. These are common technical problems which we see as a lab perspective. So we also, that's why don't encourage much of rapid diagnostic test unless it is really required in our, at least in private setup like ours. And secondly, IgG, IgM, when they go, when they come, it's really difficult to tell, sir, because it again depends on the person's immune system. Like the sir said, maybe as clinicians, if you see, it will come down for us. What we see as textbook perspective is 7 to maximum 7 days, it should come down IgM, but we don't know for scrub, there is nothing like, I have no idea regarding scrub IgM, but dengue IgM falls within 7 to 10 days. And then that at the same time, there is an overlapping between IgM and IgG usually.
Okay.
Swati has, you said it absolutely right. For dengue, we know a little bit. For scrub,
we have no idea.
IgM may be positive for 2 weeks, for 3 weeks, we don't know. There are no such long-term studies. But yes, if you do a paired sera day 4 or day 5,
we can see the rise or fall.
And you can see a rise or fall, and that way you can decide. And what she's categorically pointed out is read the kit literature. If you do not follow the instruction, what are given on rapid diagnostic test, you might find that, somebody has left that kit by the patient's bedside and they will come back and say, now it has turned red, but that doesn't mean that the test has become positive.
Okay. I think we had a lot of good interaction and a lot of actually question and answers, a lot of enthusiastic participation, sir. So the message is clear and loud from your side. Now we are going through a typical seasonal surge of fevers, starting with influenza in the community to dengue to scrub. Maybe some of the cases were overlapped with lepto and enteric fever with the rains. So initially with early respiratory symptoms, influenza cases, milder form of any viral infections in the initial couple of days may not need any investigation or evaluation if they are stable and in the milder without any comorbidities. But if the patient persists to beyond 72 hours and you have any complications related to those diseases, you may need the diagnostic test. To start with, you need to exclude the malaria, as you said. We are still an endemic country and malaria is a treatable disease. You don't want to miss a malaria to allow a patient to land up in complication. So you have rapid diagnostic test, parasite and VNF. And if you have suspicion, you repeat it so that you will have a negative predictive value of 2 negative tests, which is close to 90%. And then you suspect your COVID, influenza, which is the next common things, which depending on your respiratory symptoms, or If you are leading to any complications or in the later phase of your week, dengue with a right now the surge with severe myalgias, breakbone fever with retroorbital pain, rash, you may consider the differentials to them beyond 5 days or so. Your scrub comes into a play. If you have a hepatorenal phenomenon, clinical context, your lepto can be a phenomenon. Scrub and lepto, the antibody-based techniques, PCR-based techniques are available, but they are all need to be in the clinical context based. And both of them emphasize you need to read the instruction, know whether you are dealing with a PCR, it should be early. Antigen-based, it should be early. You need to know the sensitivity, specificity, false negativity, false positivity, cross-reactivity before interpreting them. And antibody testing may be done in the later part of the week to get its more accuracy. And last part is probably they talk about lepto. The initial week you may get negative testing, but if you repeat it, you may get a positive testing. But empirically, all these patients probably receive a doxycycline as an empiric choice. And one more important point which Dr. Ashish Bhalla has emphasized is you need to know whether after investigating with this so-called syndromic panel, am I going to give any therapeutic option to the patient? So if it is a meningitis other than acyclovir, do I have any other option to add to that? That is one. Second, in the respiratory panel, in upper respiratory panel, other than your oseltamivir, other than your COVID virus, do I add anything, add to existing viral panels to treat any viruses? Maybe a atypical coverage in a patient with a community acquired pneumonia is an add-on. And now, right now, along with this respiratory panels, we do have a urinary antigen testing for Legionella, Streptococcus pneumoniae, which can be an added phenomenon in that. So I think they give a very wide varieties of wisdom to us. And we thank Dr. Ashish Bhalla to give his time to share his wisdom, share his knowledge, his clinical experience in this forum. Any final take-home message from you, sir?
Use any test in light of what is happening to the patient. Do not order Vidal, on day one, and do not order dengue NS1 when the fever has been persisting for more than a week. So these are the things which, you need to think. There is nothing called a fever panel, because if you do a lepto and, scrub IgM on day 2 or day 3, you're not going to gain anything. So use your test wisely, because if you have more number of patients and you burden your microbiologist with a panel of tests, they are also going to have problems in either interpretation or transcription of the report.
Thank you, sir. Thank you for your valuable opinion. I thank Dr. Swathi ma'am for presenting this overview of the diagnostic test and all the participants for their enthusiastic participation. Thank you, sir. I conclude the session. Thank you all.